Hello and a very warm welcome to this INICET exam, community medicine, MCQs and some of the topics recall discussion. So I know that this INICET exam and in fact the NEET PG entrance exam, they had been a roller coaster ride because of so many uncertainties involved. And now this community medicine, it was an icing on the cake, that you had this tidal MCQs, you had the high tides and you had the low tides. In simple words, you had the very difficult questions, and some of the questions were low tide. They were very easy, they were basic and very simple to two questions. So, in fact, if you talk about the analytics of the community medicine MCQs, we can broadly classify into five major topics. You had questions as predicted on medical research. You had couple of questions on healthcare and administration, and mind you, students, that this is the forte. It is the main focus of the aims and the INICET exam, that is healthcare and administration and management. So of course, as expected, you had couple of questions from public health, the national health programs, the communicable disease, non-communicable disease. Of course, as expected, again, couple of questions on COVID-19 and some miscellaneous topics from here and there from community medicine. If you look about the burden of the topics on the INICET exam from community medicine, maximum questions were from public health, communicable disease, non-communicable disease, and the health programs guidelines. And as expected, I told you that the forte of these aims exam, the INICET exam, is questions from medical research and healthcare administration. In fact, these two topics, the questions from these two topics are usually of high difficulty index. That's what I always say in the lessons, in the lectures, in the classes also, that the questions will be high difficulty, but the other questions from other topics, they are very easy. And that's what kind of the students would say that wow, the questions in community medicine, they were very tough. In fact, only few were tough, and they are always, almost always, from these two topics. So anyways, let's get started and talk about the MCQs. Before I talk about the MCQs, these are some of the website links that I had selected to take as the resources. So these links will also be available in the description box for this video. So you can have a look at the links and read more in case you're more interested into these. So let's get started about the medical research, the first MCQ. In fact, the first MCQ was one of the very controversial, in fact, not controversial, we would say that it is one very solid topic. So which of the following studies will show equivalence? Will show what? Will show equivalence of the new drug. So this was the image that they had seen. Now there was comparator drug, zone of equivalency, superiorities, and things like this. So you need to learn three things in this now. The first thing you need to know is, what do you mean by the equivalence? That is the first MCQ. You should know what do you mean by zone of equivalency, or what do you mean by equivalence. Second is, what is this? What is this line? What do we mean by these lines? Third is that what do you mean by comparator drug, superiority? What is this diagram about? So there are three MCQs, question 2 and question 3 and question 1. So three topics I need to tell you before you can solve this MCQ. All the students who had already listened to my lectures with full eyes and ears and heart open, probably you would have understood the concept and marked the right answers. But anyways, let's just discuss these. So first is, what do you mean by equivalence? So whenever you're doing a clinical trial, why do you do a clinical trial? You do a clinical trial because you have recently discovered a new molecule or a new treatment or a new drug, something new you have discovered. So you want to test how does this new drug work vis-a-vis in comparison to versus a standard drug. So you already have a standard drug, or you already have a standard regime. You invented a new drug and you want to see that how does this my new drug work. That's what this is known as a clinical trial. You can randomize, you can not randomize, non-randomized, quasi-trial, whatever you want. So now, what is the outcome of this clinical trial? Now try to understand. The outcome is, let us say that this is a new drug. If this is a new drug, I am going to test this new drug for the standard drug. So maybe that this new drug is able to cure better, it is more effective, or this drug maybe it causes more benefit to the individual, and it somehow is superior to the standard drug. If this is the case, then it is called as a superiority trial. So mark the word, it is a superiority trial, that this new drug is superior to the standard drug. Or sometimes you can just take the reverse angle. I'm just going to show you the same thing in a different scenario now, that sometimes you can do a trial where this new drug, mark the words, where this new drug, let us say that the standard drug is there, the standard drug already will have some adverse effects. Simple, it will have some adverse effect. So let us say that the standard drug was having some adverse effect. This new drug, it has adverse effect which is lesser than the standard drug. So we can say that the new drug is not inferior to the standard drug, or in simple words, it is not as bad as a standard drug. So this drug is better. Why? Because it's not as bad. So these are called as non-inferiority trials. That means this new drug is not inferior to the standard drug. Or you can do another thing, that is, you can say that this new drug is equal to the standard drug. Most of the clinical trials and most of the medical industry, we are doing non-inferiority trials, that we want to say that this new drug, whatever the new vaccine, the new trial, the new drug, the new intervention you have invented or discovered, this new trial is not inferior to the standard drug, and therefore it should be incorporated into the management guidelines. This is what do we mean by the equivalence studies or the non-inferiority trials. Once you have understood this, now let me show you what does this diagram mean. So in the diagram, let us say, before I discuss the diagram, you have to learn that what is odds ratio, what is a p-value, what is a confidence interval or a confidence limit, and what do we mean by the test of significance. You need to know all the concepts in this. So you should have, if you have watched all the lectures on Marrow application, you would be able to understand it much more in detail. So anyways, let us say that this is the zone of equivalency. Let us say that this is the equivalency zone. Okay. On one axis, on the far end of the diagram, this is what is the inferiority limit. Inferiority limit. What do you mean by the inferiority limit? That let us say that this new drug is there. Before we analyze this new drug, I have already set a range that if my new drug will fall within this range, I will say that this trial is effective. So within the range, there is a lower limit and there is a higher limit. So the lower limit is, what is this? This is called as minus delta. So delta is the lowest limit, below which you will say that my new drug is not effective. There is a plus delta, above which you will say that yes, this drug is highly effective. Right? So this is the range within which you will have the results of these studies. So this is the superiority side, and then you have an inferiority side. Okay. So now, the third is regarding the confidence interval. You already know that this is a normal distribution curve. In this normal distribution curve, you have within plus minus 1 standard deviation 68%, plus minus 2 standard deviation or standard errors is 95, and plus minus 3 is 99. So now if I just plot the confidence intervals or the confidence limit on this diagram, if I plot the confidence interval, let us say that a trial was conducted and it showed the result like this. What does this mean? This is the trial number A. What does this mean, beta? It means that this trial, this A trial, it is not equivalent. It is not equivalent to the previous study. It is not inferior. In fact, it is kind of superior to the previous or the standard treatment. So inferiority means the lower limit with the standard treatment, right? And the superiority means the highest limit with compared to the standard treatment. So the more a study will be towards the superiority, that means it is more better in terms of maybe the effectivity of the drug. So let us say that this study number A, what does it mean? It means that it is superior. In simple words, in other words, can I say that this drug, this A drug, it is not inferior also. So it is a non-inferior superior drug. Let us say a drug showed the result something like this. What does this mean? That means that is this drug number B, is this drug B superior? Maybe, may not be. Sometimes it is superior, sometimes it's not superior. Sometimes it is equivalent. So is it inferior? Answer is no. So this drug is not inferior. It is not inferior to the standard drug, but it is not superior also. It is equivalent. So we can say that sometimes it is superior, sometimes it is inferior, sometimes it is equivalent. So it is equivalent, not inferior drug. What do you say about this? Let us say that there is a study, trial number C or drug number C, which shows like this. So this trial number C, that's interesting. Now this trial number C, it sometimes shows this negative effect or the inferior effect. Sometimes it shows a equivocal effect or towards the equivalent zone. Is it superior? Definitely not. Is it inferior? Kind of. Sometimes it is inferior. So in this we can say that non-inferiority is not shown. It is not shown. Non-inferiority will not be shown. Are you understanding? We just twist the words. So the non-inferiority is not shown. Why? Because it is kind of inferior. It is not equivalent. It is not superior also. If you have understood this, now let me come back to this diagram and talk to you more on this. So what do you mean by this lines A, B, C, D, E? Which of the following studies will show equivalence? So it's as easy as that. Let us just zoom into it. So what do you think about this study number C? Beta, study number C. Study number C, does it lie in the we are supposed to talk about the line only. You don't want to actually talk about the medians. You do not want to see the medians. We can see the medians, of course, but in this MCQ, pertaining this MCQ, you just see the lines. So if the line is touching the zone of equivalency, that means it is an equivalent study. D is definitely equivalent. It is very much equivocal. There is no difference with the standard drug. So it is equivalent. E is also equivalent. But F and G, what do you think about the F and G? They are definitely superior, but towards superior. It is not, we don't say that, they don't do like this. If it had been showing something like this, then we would have said that this is definitely superior. But F and G, they are non-inferior, but they are superior. What about B and A? They are definitely, they are again not inferior. They don't show inferiority, right? So they are not inferior, but they are not equivalent and not superior also. So in fact, they are kind of inferior drugs because they are towards the inferiority only. So they are as bad as the standard drugs A and B. So what are you going to mark in your MCQ exam? Which of the following studies will show equivalence to the new drug, of the new drug compared to the standard drugs? So definitely we are going to mark C, D and E. All three will show equivalence. So which of the following is true? So C, D and E, all three will show the equivalence. You actually don't want to look into the medians because the confidence interval, the lower and the upper limits are going to decide the equivalence of the new drug. Right? So now let us come to the question number 2. The refer to the image. 4 groups of homogeneous sample were taken and the height and weight of each group had correlation coefficient of 6. The total correlation coefficient of the combined group will be. So there are different researches on this. The point to be noted is that 4 groups of homogeneous sample was taken. So the sample was homogeneous and the image they had shown was something like this. So you have 4 different colors. So you have color 1, color 2, color 3 and color 4. So in case the samples were homogeneous, so in those cases, if the correlation coefficient or the Pearson correlation coefficient of each group is 0.6, the total would be equal to the same. It is equal to same in case it is homogeneous. In case it is not homogeneous, now we need to do Fisher exact test. We need to do some test of significance to find out what is the average correlation coefficient. So in this question, they were very straightforward with this, that what is the average correlation coefficient? Answer would be that it is equal to 6. So the best answer over here would be equal to 6. So there was a very old time study on combining correlations. There was an article on this, so by Richard A. Charter. So you can just read that the averaging is not the method of choice when the number of samples had been drawn and each sample is drawn from a different segment of the same population. But in case you are taking from the same population, homogeneous population, you can use simple averages. So the best answer over here would be equal to 0.6. Next is this question number 3. Which of the following statement is true? So PPV increases with increasing prevalence. Sensitivity depends on prevalence. Specificity depends on prevalence. In low prevalence, positive of a highly sensitive test means true positive. We have discussed this question beta so many times in the videos. It's a very simple, direct question. If you are getting this wrong, you need to work hard on your questions from sensitivity, specificity, screening of disease. We have discussed this so many times. So which of this following statement is true? You already know that there's the box. There is a disease plus, disease minus, and there is a test plus, there is a test minus, there is a true positive, there is the false positive, the false negative, and the true negative. So you know that the positive predictive value is directly proportional to the prevalence. So as the prevalence will increase, so what will happen if the prevalence increases? The table will shift like this. So if the table is shifting like this, so the TP will increase, the FP will decrease. So what is going to happen to the positive predictive value, that is TP divided by TP plus FP, that is the PPV will increase. So the prevalence increase, the PPV increase. The first option is absolutely correct. So this is the true option. Sensitivity depends on prevalence. Specificity depends on prevalence. This is false option. We have done this so many times. Please note that sensitivity is nothing but true positive. Sensitivity is nothing but true positive divided by the D plus, and specificity is nothing but true negative divided by the D minus. We have done this, right? There's no role of prevalence. In low prevalence, positive of highly sensitive test means true positive. It doesn't make sense because you're crossing the tables. Please note that the rule is never cross the two sides of the table. So this is also false. So which is the best answer to mark over here? PPV increases with increase in the prevalence. This is the correct answer. And now the question number 4. The graphical presentation of the flow cytometry analysis is done by which of the following? The bar and dot plot, histogram dot plot, line diagram dot plot, and pie chart dot plot. I think we all have studied, we all must have seen a flow cytometry analysis report. Answer is not a pie chart any day. It's not a pie chart. If you would have seen a flow cytometric analysis that looked like something like this. So what are these? These are simple dot and plot. So these are something dot plot charts, or we call them as scatter plots. So they are technically scatter plots or dot plot charts. And what are these? Now this is where the confusion starts. These structures could be looking like a line diagram. They could be frequency polygon, or they could be histograms as well. So under technical terms, these are histograms. These are what? These are histograms. They are not line charts. So let's just rule out options. They are not line charts. They are not line charts. Why? Because there is no element of time. Because there is no element of time, they are not line charts. Now the problem is whether this is a frequency polygon or a histogram. So technically speaking, this is a histogram. Frequency polygon is nothing but joining the midpoints of a histogram. So this is a histogram, which is a shaded histogram itself. So you don't have to understand anything. It's just a simple question from the graphical methods that flow cytometry, the best answer for you to mark over here would be a histogram and a dot plot. Next, let us come to this topic, healthcare management and administration. So let's talk about this so much controversial and so much sparky questions, so many reviews, so many queries coming on all sorts of social media platforms that let us discuss about this. So all the students who have already worked in the field, for them this must be a very simple, basic, easy question. But for those students who are just relying on the studies, for them you should be knowing this about the reorder level. Somewhere in the sessions also we have discussed about this. At a PHC, 50 patients were transferred from another center and required antihypertensive treatment. 40 people were given amlodipine. 10 have contraindication to use of amlodipine, therefore lisinopril was given. The drugs are supplied on monthly basis. That is an important information you should be looking at. So how many medications will you be ordering extra with a reorder factor to maintain the stocks and provide healthcare to the community? So you should be knowing that what is a reorder level. The reorder level, beta, please remember that reorder level is the average monthly consumption multiplied by the reorder factor. What is this reorder factor? The reorder factor is just a number which is a multiplicative number. It depends on the lead time. So what is the lead time? Lead time is the time required to procure the drugs or the supplies. So to procure the supplies is what is lead time. If the procurement of supplies is done on monthly basis, the reorder factor is taken as 2. If it is done on 3 monthly basis, the reorder factor is taken as 6. Right? So just remember 3 monthly is 6 and 1 month is 2 times. So that's the most commonly that we are using in public health system in India also. So based on this, you already know that there are how many people are taking amlodipine. So we already know that amlodipine is for 40 individuals. So each one is taking, let us say, 1 amlodipine a day. So it is 40 times 1, that is 40 tablets. And then you have 10 people taking lisinopril. So 10 into 1, that is 10 again. So it is 50 tablets for each day multiplied by 30 days. That comes out to be 1,500 tablets. So 1,500 was not there in the option. In fact, you should also keep a stock for 2 days. So that can be like extra 50, that is 100. So the reorder level should be 1,500 plus 100, that is the safety level, multiplied by a reorder factor, that is 2. Why 2? Because it is procured on monthly basis. So that is what your answer should be, that it should be 1,600 with a reorder factor of 2. It's a direct MCQ, but of course you should be knowing about the formula for calculating the reorder level. Next MCQ, which of the following is not included in the criteria for an essential drug? So essential drug list is a new chapter in PARC 26th edition also. We have discussed this in the updates also. So it's a direct question, and in fact, even if you have not studied, anybody can rule out the options. See, the essential drug is a drug which should be in line with the treatment guidelines for a public health problem. This sounds like a true option. The drug should be cost effective. This also looks like to be a true option. The clinical trials must be with proven efficacy. This is absolutely true. Now, the point is that the fixed dose combination is better than the individual drugs. The problem with the fixed dose combination is that you will have to adjust them for the weight, for any comorbidity, somebody having liver problem, somebody having kidney problem. The fixed dose combination should never be, are almost never included in the essential drug list, because the essential drug list are simple drugs which are single drug, individual drugs to be given in line with the treatment guidelines for any public health problem in our country. So the criteria for essential drugs that should be that the medicine should technically be approved in India, useful for a disease which is a PHP in India, public health problem, proven safety, proven efficacy, should be cost effective, aligned with the current treatment guidelines, stable under storage conditions. The price of the total treatment is considered, not the unit price. This is an important point, and this could be your prospective MCQ also, that the total treatment is considered, not the single unit price. And this was this year's MCQ, that the fixed dose combination is generally not included. And the essential drug list is different for the primary level centers, secondary level centers, and the tertiary level centers in our country. So which of the following is not included? The best answer would be your option number A is the best answer over here. Fixed dose combination is better than the individual drug. This is a wrong answer. Moving to the next MCQ, which of the following is true for mobile medical units? MMU are government operated. Mobile medical units are run by external agencies with medical supplies by the government. Mobile medical units are government supplied or government operated, and medical supplies also by the government. Mobile medical units are external agencies and supplies also by external agencies. Which of the following are true? So I don't think there's a single best answer. There has to be multiple options which are correct. And talking about these mobile medical units, this question has been taken directly from the operational guidelines from the mobile medical units, which was launched somewhere in 2015-16, and still now it is not operational in all the districts, but in majority districts we do have these mobile medical units. The suggested model for mobile medical units is government operated mobile medical units. You can have the MMU on outsourcing basis, that is the CAPEX. CAPEX stands for the capital expenditure. So the capital expenditure and the drugs provided will be by the government. Or we can have the MMU services including the CAPEX and OPEX, that is the capital also by the voluntary agencies and the operational cost also by the voluntary agencies. OPEX stands for operational expenses, CAPEX stands for capital expenses. Capital expenses include the van, maybe the drug supplies, the initial investment, capital investment. Operational costs will include the human resource, the day-to-day supplies which are required. So outsourcing of the mobile medical units can happen with CAPEX and OPEX both. However, the drugs and supplies will be supplied by the government. So in all the cases, it can be run by the voluntary health agencies or by the government agencies, but the drugs and supplies has to be from the government of India. So based on this, what is your best answer? Option A stands true. Option B is run by external agencies with the medical supplies by the government. This is also true. Run by the government and medical supplies by the government. This is also true. It is run by the external agencies and supplies also by the external agencies. This is false. So supplies cannot be by the external agencies. So which of the following is true? True would be option A, B and C. All three are true. In fact, the D is the only option which is not correct. Next question, question number 8. We will be spending a little bit more time on this question because I'm not sure about the recall, but yes, most of the students have given this report that as per verbal autopsy report dated 2010-2013, that is 10-year-old data, arranged the causes of death of children 1 to 4 year as per the following this thing: diarrhea, pneumonia, malaria, injuries. So you have different this. Now the variant of this question, it may be, I don't know the real question, but the variant is as per the National Birth and Death Registration CRS 2019-20. We are talking of the age 1 to 4 years. This will be different answer. If you're talking of the birth and death of 2010-2013, age 1 to 4 years, this will be different answer. And if the question was on national survey data 2013, age under 5 years, under 5 years is different answer. So let us first talk about this because this is what the most recalls are, that the verbal autopsy report was asked in the question 2010 and 2013. I don't know, in many times in my live sessions we have discussed that even I was a part of the million death study. So MDS is a million death study where the government of India in collaboration with the WHO and the Center for Global Health Research, that is the CGHR, Center for Global Health Research, they collaborated to do this million death study to study the millions of death, like 1 million death to be studied, what are their causes. So they had given this data from 2010 till 2013. The report of this data 2010 till 2013, it shows that maximum number, top 10 causes of death, top 10 causes of death in age 1 to 4 years in year 2010 till 2013. The maximum was for pneumonias. Second was for diarrheal diseases. Third is for injuries. And finally for malaria. So what is your best answer? In case this was the question, the best answer would be that you were supposed to put them in order. So you had the option pneumonia, B, and then we had the diarrhea, that is option A. Then we had the injuries, that is option D, and then we had malaria, that is option number C. So this was your data. This is the link also, and the link will also be available in the description box for you to have more insight into the data. And this is the top 10 causes of death. If the question was the verbal autopsy report 2010-2013, that is under the CGHR report. Now, In case the question was for medical cause of death under the SRS data or the CRS data, civil registration system, or we have the sample registration system, we have the medical certification cause of death data, which is the updated data 2019. As far as this data is concerned, the maximum number of causes of death in India, 22%, was from infections and parasitic diseases, which include septicemia, diarrhea, and malaria. So highest was from this in year 2019, age group 1 to 4 years. So I'm telling you, the answer will change as far as what data you are talking about. So if you're talking of the CRS data or the medical certification of cause of death 2019 by the sample registration system or the CRS, that data will give us that the maximum chance of death was for diarrheal diseases, followed by malaria, followed by pneumonia, and injuries are nowhere in the top 7-8 list. So probably this question was not there. And on the similar grounds, if the question had been asking about 2013, which I myself would doubt, why would somebody ask like 7-8 year old data? But in case they have asked, then the data will actually change, right? So the point of confusion, you might be showing me this snapshot, this image from the Park 26th edition, the Park textbook 26th edition. The Park 26th edition, the latest, they show that the leading cause of death in age group 1 to 4 years. Age group 1 to 4 years, the leading cause of death is diarrheal diseases, followed by respiratory diseases, malnutrition, infectious diseases. I duly understand this data, but this data had been taken from 2016 SRS data. 2016 SRS data. So we are not, we had not been asked about this data. So most common, like most probably, the recall word like the verbal autopsy report was there in the question, which makes sense that there was a million death study, which also makes sense that the CGHR data was taken, and that is the updated data we have from year 2010 till 2013. So the best choice would be to mark the options in this sequence, because this is the data that we are going to talk of, right? So coming to the next topic about the public health, about the communicable disease and the national health programs. How do you identify a diabetic case in a primary healthcare center in a peripheral setting? So in a PHC center, in peripheral setting, now there are, what are the couple of ways to diagnose a diabetic? In case I was teaching a multi-purpose worker, in case you are a multi-purpose worker, the screening modality is done using random sugars only, random blood sugar, that's all. In case you are a doctor, medical officer in a PHC, so of course the INICET exam was for all the MBBS doctors. So in case it's a doctor or a medical officer or a PHC, the screening modality is a fasting blood sugar and a 2-hour postprandial blood sugar or a post-glucose load. So the best answer over here would be a fasting blood sugar and a 2-hour post-glucose load. Please note that random blood sugars, that is for MPWs. HbA1c can be taken, but in a peripheral center, in a primary healthcare center, HbA1c does not prove any grounds, and it is expensive. It is not cost effective to be taken as a screening modality for the whole country. So just to show you that what I'm talking of, this is the data from the MOHF, Ministry of Health and Family Welfare, Government of India. So for the multi-purpose worker, that for the purpose of screening, random blood sugar is taken as a screening modality. This is for the MPWs. So this is from the guideline for the MPWs module, for the MPWs training module. If you talk about the doctors training module, so the training module for the medical officers, which was last we had in 2017, the fasting blood glucose and the 2-hour post glucose test, these are taken as the criteria for diagnosis of type 2 diabetes from the venous blood samples. So that is what is the final diagnosis on how do you screen for diabetes. Please, I would also like to tell you that about the gestational diabetes mellitus, the testing for gestational diabetes mellitus is at the first antenatal visit using a 75 grams of glucose, a 2-hour post 2-hour plasma glucose level. So after giving us 75 grams of oral glucose, 2-hour plasma glucose level. This is done at the first antenatal care visit. So this is one of the revisions, and it has been couple of times asked in your exam, right? Next is this question number 10. Safe strategy in trachoma. Which of the following is not included? So I know you must be laughing at me that why are we doing this? It is one of the very simple basic question, multiple times asked. It is age-old MCQ. Safe strategy. Safe strategy stands for antibiotics. S for surgery. S for surgery. A for antibiotics. F for facial cleanliness, and E stands for environmental hygiene. Environmental hygiene. So which of the following is not included? Evaluation of a trachoma control program is not a part of this whole system. Next, which of the following is associated with intussception? We have had a couple of words on this. In fact, there is a special mention in the video module also that intussception is strongly associated with the rotavirus vaccine. Rotavirus vaccine may lead to cases of intussception. So please note that pentavalent vaccine, in that there is a pertussis component or pertussis vaccine which may cause unconsolable cry. Unconsolable cry. Influenza vaccine is associated with certain rare side effects. It's a very rare adverse effect, Guillain-Barré syndrome. Pneumococcal conjugate vaccine is not known to have anything except the anaphylaxis or allergic reactions. Question number 12, again such a super duper easy MCQ. Pentavalent contains. Now I don't know if you've got this right or wrong, but to all those students who've got it wrong, it's a very hard luck or a bad luck, right? So anyways, I don't even know. I've filled the options myself. I didn't even care to look at the options. So pentavalent contains what? Pentavalent contains DPT, diphtheria, pertussis and tetanus, with H influenza and hepatitis B. So that is your option D, right? Question number 13. In case of HIV TB co-infection, who would you treat the patient first? So please note that whenever there is HIV and TB co-infection, we always try to treat TB first. TB first. Why? Because TB is infectious, and we are also scared of the severe immune reconstitution syndrome, because as you start treating for HIV, the CD4 count will increase, and there may be a paradoxical reaction of tuberculosis, and there may be a reactivation of the TB. So you need to treat TB first. You start ATT. ATT stands for anti-tubercular therapy. So you start ATT, and after 2 weeks of the ATT, you can start the ART. So after 2 weeks, you start the ART. So which is the best option over here? Start ATT followed by ART after 2 weeks. Simple question, simple answer. Question number 14. The objectives of Kangaroo mother care are. So this question has been taken directly from the Kangaroo mother care guidelines by the WHO. So there is a updation of these guidelines. So anyways, those updations are just based on the operational guidelines. You have to remember that what are the objectives of a Kangaroo mother care. So Kangaroo mother care is that holding the baby with a skin to skin touch. It promotes breastfeeding and promotes exclusive breastfeeding. It also promotes emotional bonding, but that is not the objective of KMC. The main objective is it promotes breastfeeding, it promotes early discharge of the patient, and it promotes skin to skin contact with the mother and the baby. So promotes the emotional bonding. So which of the following is correct? It does promote the skin to skin contact. It does promote early discharge and exclusive breastfeed. In fact, the option A seems to be the best answer. Let us look at the other option. Skin to skin contact, that is true. Reduce infection is not the main objective of the KMC. Of course, it does reduce the infection because you are doing exclusive breastfeed. Prevent infection and prevent infection. So option B, C and D are not the main objectives of the KMC Kangaroo mother care. Next is this question number 15. Match the following. Wonderful old time previously asked so many Gisapita MCQ which match the following. Lower abdominal pain, which get urethral discharge, which get Herpetic genital ulcer, which kit? Vaginal discharge is which of the following kits? So you already know that these are the kits. You have kit 1, 2, 3, 4, 5, 6, 7. Kit 1, please remember that kit 1 is a gray kit. It is given for urethral or cervical discharge. Kit 2 is a green kit given for bacterial vaginosis or vaginal discharge. Kit 3, 4, 5 all are for genital ulcers. 3, 4 and 5 all are for genital ulcers. Kit number 3 is for genital ulcers which are non-herpetic. Non-herpetic genital ulcers, standard is kit 3, which is a white kit. Kit 4 is given again to non-herpetic genital ulcers but who have penicillin allergy. Penicillin allergy. So kit 4 is for non-herpetic genital with penicillin allergy, and kit 5 is for anybody who has genital ulcers which is herpetic because it contains acyclovir and so on. So kit number 6 is for all cases of pelvic inflammatory disease or the abdominal pain, lower abdominal pain. Kit 7 is for buboes, inguinal buboes, and that is a black color kit. So coming to this question again, lower abdominal kit. Lower abdominal pain, you remember it was kit number 6. So A goes with 4. Urethral discharge, that was the kit number 1. So B goes with 1. And non-herpetic genital ulcers, they did not specify anything about the penicillin allergy, yes or no. So we had to choose between kit 3 and kit 4. Kit 4 is not there in the option. You are going to choose directly kit 3. So C goes with 3. And vaginal discharge, so BV, that is the kit number 2. So D goes with 2. So that is your best pick over here. A 4, B 1, C 3 and D 2. So you would like to go with option number A. Coming to the questions from COVID-19. So they were very easy, simple questions. You would advise all of the following on discharge of a mild to moderate COVID patient. So return if there is a facial pain or a sinus pain. I think everybody knows about the black fungus. So of course, that is one of the danger signs we do explain. Regular monitoring of sugars, that technically has to be there. So this is also true. Do repeat the PCR. Of course, you're not going to repeat the PCR. Everybody should know this. PCR is not required to be repeated after 7 days or any time after discharge for mild to moderate COVID patient. No requirement of PCR testing. Return if there is a new onset anosmia, of course, in case there is a repeat infection. So this is from the latest May 2021 guidelines that in cases of mild or moderate COVID-19, please remember that there is no requirement of RT-PCR testing before discharge or even after discharge. No requirement of RT-PCR testing. Right? Question number 17. A symptomatic COVID patient was hospitalized and now discharged. So this patient was hospitalized. The recommendation for conducting an elective surgery will be done after. So there are a couple of recommendations by the Association of Surgeons of India, ASI. So the ASI recommendations are that in all cases of asymptomatic patient, you have to delay the surgery by 4 weeks. In case of the patient who was symptomatic, so mild symptomatic patient, you should delay the surgery by 6 to 7 weeks. In case the patient was hospitalized, that's what the MCQ was, 8 to 10 weeks is the delay that is expected for elective surgeries. And in case the patient was in an ICU unit and required ventilation or anything, so we almost always say that 3 months or 12 weeks should be delayed before the patient goes to any elective surgery. So that's a direct MCQ again. The recommendation by the ASI, the Association of Surgeons of India, would recommend that at least 8 to 10 weeks should be there for elective surgery in case the patient was hospitalized due to COVID or COVID-related illness. Next is the recent guidelines for management of severe COVID-19 in children. So I think everybody knows that in children, remdesivir, ivermectin is not recommended for COVID-19. And in fact, it's a severe COVID. So the best answer would be corticosteroids. So this is again a snapshot from the June 2021 guideline for operational technical guidelines for management of COVID-19 cases in children. So in cases of moderate to severe COVID cases, we are going to give only antibiotics. We are going to check for the oxygen therapy and to give them steroids in case it is required for severe. Please note that remdesivir and emergency use authorization is not recommended in children. Right, so coming to the miscellaneous topics, the last portion, which of the following will be discarded in a black bag? So black bag is under the solid waste management guidelines. So under the solid waste management, please note that the solid waste is not the biomedical waste. So under the solid waste management guidelines, will you do the contaminated linen? Answer is no, it goes to the yellow bag. Contaminated gloves? Answer is no, it is a red color bag. Gloves, so any types of gloves would again be red color bag. Gloves paper covering, the covering paper or the wrapper of the gloves, of course that goes to the solid waste, that is not a biomedical waste, so it will be going to the black category or the black bag. So now moving again to the next very easy question, which of the following supplement is nutrient is required in higher doses as per the recommendations for daily allowance of a lactating female? Options given were vitamin A, calcium, iron, and probably folic acid. Even if it's not there in the option, something else. There are some more important points I want to discuss with you. This question has been taken from the RDA, recommended dietary allowances update by NIN in year 2020. We have already discussed this couple of times with emphasis, special emphasis on calcium in our video lectures, in our all classes, live classes as well. So beta, please see that the calcium, and this snapshot I'm showing you from the recommended dietary allowances notebook. So for lactating female, an additional amount of 200 is added to the EAR, that is the average energy requirement of 800 and total of 1000 has been set as EAR, and adding 10% CV, the RDA is set at 1200 milligram. So that is what you just need to remember, that extra 200 is specifically added for a lactating female. If you talk about a pregnant mother and a lactating mother, so in pregnancy, of course, you need more energy, you need more carbohydrates compared to a normal female. You need more iron, you need almost very high amount of iodine, but the same amount of calcium, but the calcium over here is on a higher side. So calcium for pregnancy and for normal female and for adult male, it is same. Calcium is required for lactating mothers and for post-menopausal females in tune of 1200 milligrams per day. Vitamin A is another option which was there in the MCQ. Vitamin A, do you require extra? Yes, we do require 50 micrograms extra, but that 50 is not as important as compared to the calcium. Moreover, the calcium supplement nutrient, you're talking of a supplementary nutrient, whereas vitamin A, please note that you don't need to take extra vitamin A supplements. So vitamin A, whatever you're getting from the diet, that is sufficient, but in case of calcium, you need to take extra supplements of calcium. So that all the more tells you that which is the better answer to mark. In case it is a single best answer, please go with calcium. Calcium is much better answer than vitamin A. Of course, both answers are true. Calcium is more, vitamin A is more, iron is less in lactation, folic acid is also less in lactation. As you can see just near me, it is 330 and this one is 570. So you can see that this is again a fairly easy, simple MCQ. We've discussed this couple of times. Next MCQ, question number 21. Most common mode of absorption of inorganic lead in the industries in lead poisoning: skin absorption, inhalation, ingestion, or contaminated hands. So in case it is a child, if this was question for a child, for inorganic lead, it would have been mostly ingestion for a child. But this question is in industries. Inorganic lead in industries would not be for a child, it will be usually for adults, and most common route we have already talked a couple of times is inhalation. So please note, this is again a direct MCQ. It is inhalation as the most common route for absorption of inorganic lead in industries in lead poisoning. Question number 22. Point C in the following diagram represents. So you have a stage of susceptibility. Then you have a stage of subclinical disease. So that means the disease has started. So point A would be corresponding to the pathogenesis actually. Point A is pathogenesis. Then is this subclinical stage. And then there is a clinical stage. So what is the demarcation of a clinical stage? Like, how do you differentiate between a clinical stage and a subclinical stage? That is predominantly by the onset of the sign and symptoms. Next is point number D, that once you have the sign and symptoms, then you are going to diagnose it. So point D corresponds to the diagnosis. So point C corresponds to what? It corresponds to the onset of the clinical signs and symptoms. Fairly easy, direct MCQ. And so with that, thank you so much for watching this module. We are always welcoming your queries, your doubts on these all social media platforms. You can contact me on Telegram group, on Facebook groups, Marolinks group, my own Mukhmohit's Community and Medicine Discussion Group, Facebook page, Instagram handle as Dr. Mukhmohit. You can also visit my website PSM Simplified and Mukhmohit.com for all the PSM related updates. And the disclaimer is that all the MCQs that we have discussed over here, they are recall questions, right? So what you have recalled, what your friend has recalled, there might be differences, but I have tried my level best to give you some authentic explanations, and the authentic links are available in the description box. So take care and keep on revising, study hard, and all the very best for your results. All the best. Bye bye. Take care.